this is a follow-up brain CT scan for the same patient. I will go to the last cut and then come back quickly. I can see that there is a large extra-axial crescent-shaped hyperdense acute hematoma seen involving the right frontoparietal and extending into the right occipital and right temporal lobe. This giving the appearance of large right-sided subdural hematoma because it can cross the suture line, and I can see that this mass lesion causing loss of the sulci gyri on the right cerebral hemisphere, representing edematous changes associated with severe shift of the midline structure to the left side and severe compression onto the right lateral ventricle. Because of this appearance, this is an urgent case, and I will urgently pick up my phone and confine my finding to the referral doctor. And I can also notice that there is also blood or hyperdensity noted in the cistern, which could represent also associated diurite hemorrhage. This is an urgent case, and I will urgently confine my
Where have
finding
you
to
picked
the.
up diurite hemorrhage? Where have you picked up? Can you
Yes,
point it out?
at this cut.
Where is it?
Well, let me scroll.
Yeah. Okay. Let me ask you a few questions.
It is
Don't move
yeah,
your,
jumping, but
excuse me.
yeah,
Don't move your mouse. I'll ask you a few questions. What's happening here in the cerebellum?
I'm not moving. This is yeah. I think in this left cerebellar hemisphere, I can see that there is area of hypodensity seen in the left cerebellar hemisphere, and I think this is due to most likely shifting or herniation onto the left side that is causing compression onto the vertebral artery, left vertebral artery, and its branching, resulting on secondary infarction.
What's happening here?
Here, I think there is a severe shift of midline structure into the and compression onto the right lateral ventricle, and I can see that there is also hypodensity centered within the right thalamus or hypothalamus, and mostly due to secondary infarction, because maybe there is compression into the right middle cerebral artery.
What is happening here where I'm pointing out? We can see this hypodensity. What is happening here?
Yes, this hypodensity, I can see it is a parafalcine, and I think it is extending anteriorly, adjacent to the interhemispheric fissure. And I think this is the territory of the right anterior cerebral artery, and this is could also represent infarction within the right anterior cerebral artery.
Okay, thank you. Now, this case is a case of subdural hematoma. It was a subtle subdural hematoma which was missed. I'll show you what was missed. And this is a real life case. over the last 15, 16 years, I think I have seen that five similar cases. And actually, I've been in the coroner's court quite a few times as a witness also for these kinds of cases. So I always highlight to my trainees, always look for subdural hematoma window. And one mistake can be a very big mistake. It will be a fatal mistake. This is one of the cases from my collection in which what happened was that if you look carefully, there is a small subdural hematoma. What happens that on a normal brain window, it is difficult to differentiate it with the adjacent bone. So subdural hematoma window, which is this one, it makes the brain slightly darker and the hematoma appears different as compared to the adjacent bone. So this will be the savior. This particular case was missed. The patient was sent home from A&E and became unconscious, was living alone at his home, and later on was brought in. Because he was unconscious, the neighbors alerted the police, and then when the patient came in, this is the picture. So had a subdural hematoma. And this is the subdural hematoma window. Literature tells us that the level can be 75, width can be anywhere between 150 to 200, but to keep it simple, this is what I use, 75, 175. Please remember that in any trauma case, there is absolutely no need of using it in non-traumatic cases. In trauma case, always use it. And even if once a decade you save a life because of this, it will be enough. Uh, Another example, I've got quite a few, but this one, if you see, this is usual windows, and is something happening there? Difficult to see. And then you can see this subdural hematoma window. The case which I am showing you, I was just doing an experiment on Usirex, and it is a very, very subtle case. On our packs with high resolution, it is more convincing. So I'll show you on Usirex. The resolution might not be as good, so I've made a PowerPoint also of screenshots just to highlight what was missed. So if you see here, very subtle finding, something is happening here where I'm pointing out. And this is the usual window. This is the subdural window. Actually, I think so. This is the usual window, and this is the subdural window. Now, what happened was in this case, this is a counter coup type of injury, which is very rare to happen like this as a counter coup subdural. But in old age, what happens is that because of the CSF spaces are quite enlarged, and because of that, the cortical vein, they are torn very easily. If you see here, the impact was here, and this is a counter coup. So hypothesis is that these were cortical veins there which just got torn apart. And I will show you the coronal. And on coronal, this is the usual window, and this is the subdural window, more convincing if you see here, and particularly if you see here. So this was missed. And this is just to highlight on axial and coronal, the same thing once again. Now, this is where it is, where I'm pointing out, very subtle, and this is on the coronal. This is on the coronal. So this was missed, and that then what happened? Now, please remember, this is a very good teaching case to teach you herniations. And but my aim was not to teach you herniation, but anyway, I will go through it very quickly. This is a case of subfalcine as well as transtentorial herniation, sort of an exam case. When an examiner will show you this, then they will see your description and your concepts. In subfalcine herniation, what happens is that, uh, you know, there is midline shift under the forks. So what will happen that the ipsilateral, so this is the mass, the ipsilateral ventricles, they will be compressed and the contralateral will be dilated, particularly the occipital horn. And this is so because the foramen of Monro, which is somewhere here, is compressed. Then in transtentorial herniation, this is an absolute blatant case of transtentorial herniation. Basically, what happens is that the medialmost portion of the temporal lobe, it herniates into the hiatus. In this case, actually, it is sitting somewhere here. It has completely dipped, and that is why the midbrain is completely distorted. So this is the pons, and where is the midbrain? You cannot make sense. There is a bit of ambient cistern here. Where is the ambient cistern here? You don't see it. So midbrain is completely compressed and distorted and displaced to the other side. If you see the suprasellar cistern, anterior to the midbrain is suprasellar cistern. The suprasellar cistern is completely lost. You don't see it. So this is also, you have to highlight this to the examiner, that the effacement of suprasellar cistern. And then if you see this cerebellopontine angle cistern, ipsilateral cerebellopontine angle cistern will be larger as compared to the contralateral side. In this case, very interesting secondary findings can be seen. One is that if you see here, this is the territory which, we are talking about vascular territory. What is the territory of anterior cerebral artery? It touches the midline, and you can see this hypodensity, and means the candidate did mention that anterior ACA, that is compressed and there is an infarct. Then posteriorly, there is an infarct of the PCA. And please remember that portion of the supply of PCA can be in the ipsilateral thalamus and even the medial portion of the temporal lobe. Something very rare has happened, but in this case, rarely it's a sort of a case report that transtentorial herniation can cause infarction of the contralateral superior cerebellar artery. So this is another thing which we see it. Bottom line is that this was again a case of subtle subdural hematoma, which was missed. And this is the CTPA of the patient, which of course I did not want to show you, but this is what happened after the CTPA. You can see these filling defects, bilateral, quite significant. That caused the death of the patient. Okay. Candidate 1, your case.
Yes, sir.
Okay, so this is a 85-year-old male, generalized abdominal pain, not opening bowel since 6 days, rule out obstruction. Rule out obstruction. This is an A&E case. Over to you.
Yes. This is an axial images of the abdomen and pelvis with IV contrast for an adult patient to rule out intestinal obstruction. I will take a brief look, and then I will come back.
Please concentrate particularly on bowel, but you have to see other things also.
my finding. It is a little bit jumping, so sorry, sir, I didn't hear you.
Do you want me to scroll it for you?
Yeah, of course. Yeah, thank you.
So first of all, just concentrate on bowel, right?
Yes, I will. Yes. Yes. In this case, I can see that the stomach is distended, and somehow it's show an air fluid level. So I will go to assess the duodenum and jejunum and the rest of the small bowel. I can see that there is multiple dilated small bowel lobes that showed multiple air fluid levels. Uh, I want to check the hernial orifices of this patient. I cannot see any gas within the non-dependent part of the colon, so there is no evidence of pneumoperitoneum. Here, I want to see the hernial orifices at the last cut. I can see that the hernial orifices appears clear. In my routine practice, I want also to change this into the lung window to see if there is any evidence of pneumoperitoneum.
There was no
I
pneumoperitoneum. No
Okay.
pneumoperitoneum.
Yes, I can see that there is thickening seen involving a few segments of the small bowel. However, I can see that there is a normal enhancing pattern seen in the small bowel lobes. I am looking for any transitional zone or any signs of feces sign to detect any transitional zone. I cannot see any feces sign or transitional zone. I can see that there is gas seen within the rectum. The sigmoid colon appear collapse with some of diverticulosis. There is no evidence of diverticulitis. Yes,
Okay, I'm showing you coronal, and I want you to just concentrate on the small bowel. Can you pick up any cause
okay.
of this obstruction?
Okay. I'm checking the coronal images. Yes, my only concern is that there is like a long segment of thickening seen involving the small bowel in the pelvis area. If you can see my mouse, I can see here, in comparison of this segment with the rest of the segments, I can see that there is long segment of transfer wall thickening, and I can see that there is multiple gas foci noted within the lumen, which could represent a feces sign that is usually seen before the area of transitional zone. Here I can see that there is narrowing of the lumen and associated with thickening of the wall. I want to inspect this lobe in the axial images. The corresponding. Yes, here I can see that there is thickening of the, yeah, it is a long segment with circumferential thickening. I want to see, yeah, after that, yeah, here in this area. Yeah, I think this is the area of the transitional zone. I want to change the window because I feel that there is a hyper dense lesion or something within the lumen itself, which could represent calcified stone or gallbladder stone that causing the obstruction.
Okay, if you see up here, there is a lesion sitting here. And if you go here, there is a lesion sitting here.
I didn't see the upper lesion.
This is
This,
the aorta.
yeah.
This is the esophagus aorta.
Yeah, I did. I see it. Yeah. Yes. Yeah, I saw it. Yeah.
So what do you think is happening? Give me your conclusion.
Yes. I because of the added lesions, it could be due to metastatic process such as metastatic lymph node enlargement. In the case of circumferential thickening, most likely due to carcinoma of the small bowel. Unlikely, it could be due to lymphoma, although this is not typical
Okay,
case.
please, I'll take over. Thank you. This is carcinoid with small bowel obstruction. Now, carcinoid, what is carcinoid? Carcinoid is a neuroendocrine tumor, and it is the most common primary small bowel malignancy beyond the duodenojejunal flexure. So please remember, it is so common. I mean to say, within small bowel, it is a very common tumor. And so what happens is that uh, it can be, the concept is that carcinoids can be multiple. Always when you find 30% of them are multiple. What happens is that carcinoids, they arise from the submucosa of the bowel wall. And instead of causing obstruction, they can cause obstruction, but more common pattern is that they breach the muscularis and go into the mesentery. When a carcinoid, if you pick up a carcinoid which is 2 centimeter in size, then vast majority, 90% of them will already have, will show you metastasis. The most common site of metastasis is the mesentery. Interestingly, the mesenteric metastases are usually larger than the primary tumor. Then look for multiple nodules in the abdomen. Always rule out any metastasis in the liver. Please remember that a patient will present with carcinoid syndrome, which is flushing and bronchospasm and diarrhea only when there are metastases to the liver, otherwise will not. So this is a small bowel enterocolysis study just to make a point. Multiple carcinoid, if you see something is sitting here, something is sitting here, and something is sitting here, as if it is intramural and it is causing this, a sort of a filling defect. This is how it appears on a enterocolysis study. Nobody is going to show you an enterocolysis, but I just wanted to highlight it just to the concept, because now is the world of CT scan. Now, what happens is that carcinoids, remember the chemistry, and you can make your radiology as well as anatomy. Carcinoids cause desmoplastic reaction because they produce serotonin and kallikrein, which produces fibrosis in the adjacent mesentery. So the strands of fibrosis, they will appear as stellate type of appearance on a CT scan. And there can be calcification. Even here, there is a calcification. And the case which I showed you, there was a small bit of calcification in that one also. Now, because of desmoplastic reaction, the small vessels, the vasa recta in this, there will be a bit of ischemia, and there will be attenuation. And because of that, in the vicinity of a carcinoid, usually you will see mural thickening, even here. And this is because of ischemia. And another case here, where you can see a carcinoid in the mesentery with calcification. Look at this stellate type of strand surrounding it. Look at the bowel wall. Just like our case, which I was showing you, it is wall thickening. And this is what I say, that know your pathology and make your radiology. So it is very important concept. There's a case here which I want to show you, which is now look at this, and this is what exam cases are about. This is a case from my collection where this is a 39-year-old female, pain, abdomen, diarrhea. So what happened was that initially a barium meal follow through was done. You can see a sort of a filling defect here. And again, you can see that as if there is a mass which is uh, encroaching the lumen, but it is not causing obstruction till now. So this is a mass here. And same thing you will see on a CT scan. Then we did a CT scan, and here once again. So you can see that there is a filling defect within the small bowel, not causing any obstruction. Now, on this CT scan, first thing is that if you look carefully in the liver parenchyma, you can see multiple cysts. In this particular case, there is some hypodensity in this region, in this region, which is barely visible. We missed it actually when we reported it, and I'll show you what is the technique. If we had seen it on liver window, we would have picked it up. Now, as we go, here you are. You see that within the mesentery, there is a mass, and this mass is larger. I'll show you the primary mass, then the primary mass. As we go distally, you can see on a coronal, this is the coronal. So you can see this lesion in the mesentery. And here you are. This is the lesion which we were looking at on the barium examination, and look at the mesentery. Mesenteric metastasis is much larger. So we missed a lesion in the liver, and later on an MR was done. On MR, we can see an arterially enhancing lesion here and shows signal loss, washout. This is a malignant lesion. This is a window. This is usual, liver window 150, 180, or 170, something like that. 150, 188. And the liver is slightly darker. On this, you can barely see this. So in a case of carcinoma, in a case of malignancy, it is a good practice to look at the liver window as a routine, Now, let's go back to our case. Now, in this case, if you just concentrate on the small bowel, we can see that there is mural thickening, and look at this loop, and the candidate also picked that up versus this. And this is that phenomena which I was talking about. And then this is the transition point. So this is the transition point. Next to it, in the mesentery, you can see a bit of calcification. You can see a bit of soft tissue. More superiorly, as I go now, this is the pancreas. And this, if you see here, there is a lesion here. there is a lesion here, which is within the duodenal C, because this is the D2 and this is the D3 segment. And then there is another lesion more superiorly, which is this one. So this is a case of carcinoid, multiple, metastasis. And I did not show you an MRE, but just to make a point that on MRE, you can see, if you see, I'm showing you a T2 weighted sequence. This is the lumen. Actually, you can see something is there. So this is in the lumen. And next to that, you can see this mesenteric nodules. On a CT scan, what we call this is that lesion around the duodenum. But if you look carefully, there are lesions in the liver. And the patient had actually hepatic metastasis also. And even with all the techniques, these were not visible on the CT scan. So carcinoid is a very important exam case, and satisfaction of search is very important. I've shown you two different cases where you have to really, whenever you get it, you tell the examiner, I'm looking for multiple lesions. They can be, at multiple locations. Number one, I am looking for any hepatic metastasis. So this is carcinoid. Okay, thank you very much, candidate. Candidate one, I think you have got another case to go. Yes, candidate one, still this is your case.
Yes.
Okay, this patient came to A&E. He is a 31-year-old male. He is a known IV drug user. He was very septic, fever, etc. Cellulitis around the left groin and thigh. Also, he has got cough and hemoptysis. Very sick looking. Over to you.
Yes, I have been presented with chest CT scan axial images with IV contrast for drug users. I will take a general look before I comment on my finding. I noticed that there is lung changes noted most in the right middle lung lobe, which looks like a cavitary lesion. Yeah, in this lung window, I can see that there is multiple areas of ground glass appearance noted distributed in both lungs. Here in the right middle lung lobe, I can see that there is a cavitary lesion which appear surrounding by a ground glass appearance, giving the appearance of nest bird appearance. Also, I can see that there is other scattered ground glass appearance without cavitation noted at the rest of the both lungs. I can see that there is no pleural effusion. Also, I can see that there is no significant hilar or mediastinal lymph node enlargement. I want to see if there is any filling defect within the both main pulmonary artery. I want to rule out any super added pulmonary embolism, which I cannot see any significant pulmonary embolism. Given the history of drug abuser, this could be representing a cavitary lesion of septic emboli.
Excuse me.
Other differential diagnosis.
Yeah. So just 1 second. Abdomen of the patient. Continue.
Yeah. Yes. These are the axial images, abdomen CT scan without IV contrast for the same patient. I will start from the upper cuts of the abdomen, and then I will go to the groin to see the cellulitis there. I cannot see any obvious abnormality within the organs of the abdomen. Also, I cannot see any lymph node, significant lymph node enlargement, and also no free fluid or ascites is noted. Also, in my routine practice, I want also to check the bony window. However, on the left groin area, I can see that there is fat stranding in comparison with the right side, and I can also see that there is swelling of the subcutaneous soft tissue, and I can see that there is enlargement of the muscles. Yeah, I can see that there is also filling defect noted in one of the maybe could be the left common femoral vein in comparison with the right side. I can see that there is filling defect.
What is your
So
conclusion? Let's conclude it.
yeah, my conclusion. This is could first I will ask for IV contrast to confirm my diagnosis of deep venous thrombosis,
Say
which
again, what will you ask for?
to do the either ultrasound for the lower limb or to repeat this
You
with IV
know,
contrast.
first conclude. If you want to ask anything, you ask later on. Give me
Okay,
your conclusion.
my conclusion for this patient, there is filling defect within the left lower limb venous system. I'm suspected of deep venous thrombosis associated with multiple cavitary lesion with the ground glass appearance of the lungs. On top of my differential diagnosis, it could be due to septic emboli. It could be due
Okay,
to
thank you.
impartial.
Thank you.
Yeah.
So this was absolutely right. This is septic emboli second to femoral thrombophlebitis. Now, you should have a clear-cut concept of the word thrombophlebitis. When there is thrombosis, there can be secondary infections also. And when that happens, then we call it thrombophlebitis. So, and it will always be in acute phase, usually in the first 7 days or so. What are septic pulmonary emboli? These refer to the embolization of infectious particles via the pulmonary arterial system. Clinical presentation will, technically speaking, when a patient gets septic emboli, there will always be bacteremia at that point. So cultures, etc., will come out as positive. So the patient will have things like, for lung dyspnea, chest pain, cough, etc., and other manifestation of extrapulmonary primary infective focus will be visible. And this is a classical exam case, and it has come in the exam quite a few times. Similar cases, I mean to say. Now, so source of infection is what we are talking about. I gave you history, which was very kind. So I gave you too much of history. If I would have given you less history, which happens in the exam, and this happens in the real world also, because IV drug users, you cannot trust them. They might not tell you anything. So, if history is not there, even then you have to look for any cause of primary infection. So these are the various causes of septic emboli. In our case, it was infective deep vein thrombosis, but there are others which you can read from Radiopedia or whatever you. Now, abnormalities may be present bilateral, 80% of cases. This is a good sign which is visible in our case. I'll show you. Feeding vessel sign. So what happens is that wherever there is a nodule, if you start tracing it, it will abut a vessel, and which makes sense. There is an embolus there, and it will there will be clearly identifiable feeding vessel associated with lung abscess. So then when there is necrosis, there can be cavitating lesions. And of course, there can be other type of opacities, nodular opacities, wedge-shaped opacities, etc., etc. So let's go through the findings. So first of all, here, they were all picked up by the candidate. We can see a lot of haziness, soft tissue swelling. Look at the edema around it. And then there is this filling defect. We can definitely see the filling defect. And then once you see the filling defect, please trace it all the way. Is there a filling defect in the ILEX? Is it in the IVC? And in the exam, they will show you cases in which there will be more than that. And then we go to the chest part of it. Uh, so, so for example, there is a nodule here, and let's trace it. And there is a bit of wedge shape here, isn't it? And you will trace it, and you can see a feeding vessel here. So if we start doing it for all lesions, most of them you can convince yourself. So for example, there is a nodule here, and you will convince yourself that there is a vessel which is draining into it. So here you are, there is a nodule here where I'm pointing out. And if we trace it, here you are, there is a feeding vessel. So same phenomena I can show you for each and every abnormality here. Then the cavitatory lesion, which can happen. And of course, another cavitation. Ground glass is the spectrum of infection, which developing consolidation or whatever. So this was a case of septic emboli with thrombophlebitis. Okay, candidate one, thank you very much.
Thank you, sir.
Candidate two, are you with us? Let me check if the candidate is muted, unmuted. Yeah, so I have unmuted candidate two.
Oh, yes, sir. I'm there.
Okay. So this patient, fall, loss of consciousness, 72 female, rule out intracranial hemorrhage. Over to you.
Yes, sir. I like to scroll through the images.
Yeah, you can ask for the mouse.
Yes, sir. I'll just ask for a remote control. Sir, I've
So,
requested.
over to you. Over to you.
Yes, sir. So it's not scrolling. Yeah. I've been provided with plain city images. I'll just take a moment to scroll through the images. Uh, so from the given images, there is evidence of minimal SAH noted in the right high right parasagittal high frontal region. Sir, I'm not able to stop the images, like to show it where it
Okay.
is.
Leave it, please. Leave it. I'll
Yes.
scroll for you.
Sorry,
This is where it is.
yes, sir. I would like to see the bone window images to look for any fractures. There's no evidence of any subdural hematoma on the visualized images. There are age-related generalized cerebral atrophy and small vessel ischemic changes.
Okay.
I
Okay, fine.
Yes.
Fine.
I would like to go
Are
through
you
the bone
sure
window.
that this is a subarachnoid?
Yes, sir. Most likely. Yes, sir. Given the basis of history, this looks like a subarachnoid because subarachnoid hemorrhage.
Any other sequence you want to see? Any other plane you want to see?
Sir, I would like to look at see the same thing in the coronal images. Sir, the central falx also
Now you
appears like.
don't move the mouse. Don't move the mouse, please.
Yes, sir. Yes, sir. You can see we can see that this is a subarachnoid hemorrhage, which can be confirmed on the coronal images.
Can it be anything else?
So another less likely possibility, it could be a thrombosed cortical vein.
Thrombosed cortical vein.
Yes, sir. But the superior sagittal sinus doesn't look very hyperdense or bulky in size.
Hmm. So you want to confirm your finding? Do you want to do
Uh,
anything else?
uh, so based on so I would like to look at the bone window images.
Yeah, bone window was irrelevant and it was normal.
So given the patient's history of recent trauma and complaints post-trauma, this is most probably a subarachnoid hemorrhage.
Right.
If the Sir, I'd like to inform these findings to the referring clinician.
Okay, fine. Now, uh, people were not very convinced. I take your opinion. And they did an MR. Over to you.
Yes, sir. These are flare axial images have been provided. So I'm just scrolling through the images from
Just
one
go
sec.
to that, abnormality which you picked up. Just
Yes,
go
sir.
to that one.
So on the flare axial images, we can see flare hyperintensity, sulcal flare hyperintensity, which is consistent with the hyperdense area on the CT scan images. This is confirmatory, and this the patient has a small SAH in the right parasagittal frontal region. I
Okay,
would
thank you
like
very
to inform.
much. Thank you. So this was absolutely spot on. Well done, candidate too. And I really checked your confidence, and your confidence was spot on. So well done for that. And this
Thanks.
can happen in the exam also. So they will grill you, and at times, they are just checking your confidence. Subarachnoid hemorrhage, subtle subarachnoid hemorrhage, look at some sites which are important. So let's repeat that. Even go to the last cut in the, and where, just like the case which I showed you, but another one is here. And also go along the falx. If you are able to see a slightly elderly patient right and left along the forks. If there is a discrepancy between the two sides, that is another sign of or site of subarachnoid hemorrhage. This is another one in the sulcus. Interpedunclar cistern, of course, the cases which I am showing you are trauma cases, but they will not show you trauma cases. The only finding will be in subarachnoid hemorrhage in the interpedunclar cistern. And beware of this. This should be a checklist for yourself, and it will be settled. Now here, what is happening is that if you see the Sylvian fissure, posterior most portion, there is something here, and this is subarachnoid hemorrhage. You can also get this kind of a case where, because the subarachnoid is not hyperacute, it might be 2 or 3 days old. And if you see the sulci, if here, look at the sulcus here versus the sulcus here. The sulcus has got some material. And when you see that, you should be worried about subarachnoid, but you should also be worried for any leptomeningeal processes like leptomeningeal carcinomatosis or infections like TB, etc. This is a case of 6-day-old subarachnoid hemorrhage, which is no more visible on the CT scan, but on the FLAIR sequence, FLAIR is a very sensitive sequence, because on the FLAIR sequence, the sulcus has to have CSF, which has to be black. When the blackness of the sulcus is lost, you should be worried about subarachnoid hemorrhage and again leptomeningeal carcinomatosis or any other processes. This is the differential diagnosis. It's a very popular case for the exam. Sulcal flare hyperintensity, subarachnoid hemorrhage is one. Leptomeningeal carcinomatosis or bacterial meningitis, etc., is another one. So the contrast has to be given to differentiate between the two. This is a case of leptomeningeal carcinomatosis, where on FLAIR sequence, we can see these high signal intensity. And when we give contrast, you can see the folia of the cerebellum as well as the cortex here is enhancing. So I will skip this. Okay. So you...
Yes, sir.
Just one second. So the candidate did very well, where picked up the finding and then stood the ground. So your thought process was brilliant and your confidence was brilliant, and well done for that.
Thank you, sir.
And then on a flare, just to make a point, you can see the same thing. If just for the purpose of teaching, I am showing you an SWI sequence, and you can see that there is some signal, low signal there. Okay, fine. We go to the next case.
Yes, sir.
Okay, 53-year-old female, irregular bowel habits since a few months, melena, weight loss. Over to you.
Sir, post-contrast CT abdomen images of a female patient have been provided. I'll just like
Have you
to.
got the control?
Yes, sir, but it's not working.
Can you ask for again?
Yes, sir. I'll just ask. Yes, sir.
Okay, over to you. So don't worry about the chest. I am not interested in the chest.
Okay,
Just
sir.
concentrate on the abdomen.
Yes, sir.
Chest was normal.
Post-contrast CT abdomen and pelvis images of the patient have been provided. I'll just take a moment to scroll through the images. So on the scrolled images, there is evidence of bowel within bowel appearance seen in the sigmoid region. Sorry, in the rectosigmoid region. Sir, I would like to see these images in another plane, probably coronal or sagittal.
Okay, just 1 second. Just 1 second. Don't move the mouse. So I am giving you over to you.
Yes, sir. Sir, on sagittal images also, there is evidence of bowel within bowel appearance seen in the rectosigmoid region. There is also thickening of the intussusception seen. In old age patients, the most probable diagnosis for probable cause for intussusception is usually uh, carcinoma. I would just like to scroll through the actual images once again to look for any other abnormalities. So there's also evidence of asymmetrical circumferential bowel wall thickening seen in the rectosigmoid region.
So what is your conclusion then?
These findings are likely suggestive of a neoplastic etiology. I would like to inform these findings to the referring clinician, and um, the patient will require further evaluation, and I would refer this patient to the lower GI MDT for further discussion.
So imaging wise, what can you suggest?
Sir, the patient can also undergo MRI pelvis for better evaluation of the rectum and better evaluation of the.
Over to you.
I'll just take a moment to scroll through the images. So there is evidence of asymmetrical bowel wall thickening seen in the
Here is the bowel wall thickening.
so here, so that is acting as the leading point, probably. Here, sir. This is the bowel wall thickening. There is bowel within bowel appearance seen in the rectal region. So the inner bowel loop shows asymmetrical bowel wall thickening. On the basis of the age, the most probable diagnosis is likely a neoplastic etiology. I would inform these findings to the clinician and would refer this patient to a lower GI MDT for further discussion. The patient will require probably a biopsy with for confirmation, sir.
Okay, thank you. This is rectosigmoid, or should we say colorectal, whatever, intussusception, and the lead point was a carcinoma, actually, a large carcinoma. Please
Yes.
remember that whenever we see intussusception in children, it's a different ball game, and children intussusception is a very important exam case. And they might show you an ultrasound for that, and they will also ask you the concepts and of how you will treat it and things, reduction of intussusception. In the adult, whenever you see it, you should be worried about a lead, focal lesion as the lead point. So what happens is that because in intussusception, there will be attenuation of the venous return, which will cause ischemia and edema. And if it is not treated, then there can be arterial interruption and ischemia. So these words should be in your vocabulary. In the exam, they have asked these words. So this is, peristalsis, the direction of peristalsis. This segment which goes in the prolapsing part is known as intersusceptum, and this one which receives the intersusceptum is known as intersusceppium. And if you want to read a good article on very old but very good article on the radiology of it, this is from AJR to 2001. You can see that this is the entering wall, and then there is a returning wall, and this is the outer wall. And you can see how the mesentery also invaginates into it. It all depends if on a CT scan, you have got an orientation of a slice which goes vertically like this. Here you will see two, loops as in the target sign, etc. Here you will see the mesentery. Here you might see the leading mass. So bowel configuration. At the proximal end, you will see two concentric hyperdense rings. Then slightly more distally, you will see mesentery, which the key finding as far as mesentery is concerned is fat and vessels. And more distally, you might see the mass itself. Now, if you see here, this is a case of a lipoma. Here is the lipoma, and you can see this is a colic intersusception, and the mesentery is going in, and the lead point is lipoma. This kind of exam case actually will, your specificity to pick up a lipoma should be up there. So in this case, you can even diagnose the cause of it. So let's go through the case. Well done, candidate 2. You picked it up beautifully. So well done once again. And
Thank you, sir.
now, if you see here what is happening, something is wrong in this region. You can see this fat. Actually, fat becomes your friend, and that highlights that something is happening. You can see this loop. Look at this. This is sigmoid mesentery and the vessel. And this vessel actually goes into the intersusception, and this is the one of the loop of the sigmoid. And here you can see this fat actually is a good pointer. You cannot make out all the walls, but one can infer, particularly where I am pointing out, you can see this target type of appearance. And more distally, on CT scan, there is something happening, but you are not sure. On MR, the same finding. Now, this is the sigmoid colon where I'm pointing out. See how it will dip down. It is going in, and it is taking the mesentery with it. It goes inside, and then more distally, there is a fungating luminal mass. This is a fungating luminal mass. I did not show you a coronal, but coronal shows it very well. So this is the vagina, and this is the uterus and the cervix. So you can see how much is the distension of the rectum, and this is because of this mass. So colorectal intussusception because of a carcinoma of the rectosigmoid. Okay. Busy scan. I am intentionally showing you this kind of a scan, so I warn you. And in long cases, you will get these kinds of cases where satisfaction of search is there. So before you go through it, I warn you that what is the type of this case? This is satisfaction of search. The age is 79-year-old male. The patient has got deranged LFT, dysphagia, weight loss, hematuria, rule out malignancy. That's the clinical CT cap. Over to you.
Yes, sir. Sir, I'll just request remote control again.
Yeah.
Yes, sir. I'll just take a moment to scroll through the from the top. Uh, Sir, am I supposed to see the abdomen images as well?
Yes, please.
Okay, sir. So there's evidence of an asymmetrical circumferential bowel wall thickening seen involving the gastroesophageal junction with resultant proximal dilatation of the uh, esophagus seen. There are also multiple variable sized heterogeneously enhancing lesions seen in the liver. Uh, there is also evidence of a large gallstone seen in the gallbladder. Uh, there is evidence of a filling defect seen in the portal vein, suggestive of portal vein thrombosis. There is also evidence of perihepatic and perisplenic free fluid. Bilateral minimal mild pleural effusion is seen. Sir, I would like to look at the lung window images to look at any abnormalities in the lung. So there is evidence of extensive emphysematous changes seen in bilateral lung parenchyma. Uh, the lower lobe. There is also evidence of reticular changes seen in the basal segments of bilateral lower lobes. So I would also like to look at the bone windows to look at any possible bony metastasis.
Mhm. Mm-hmm. Okay, anything else in the abdomen?
But I'll just go through it once again. So the right external iliac and common iliac veins appear distended, as well as the IVC. It appears distended, and there is absence of contrast opacification of the IVC, suggestive of thrombosis.
Can it be just a normal artifact, streaming artifact?
So I'm just trying to look at it again once. So there is evidence of opacification of bilateral renal veins. So and so there is evidence of another well-defined heterogeneously enhancing lesion seen involving the lower pole of left kidney. I'm sorry, I missed it at first, like first go. Based on the pattern of enhancement, this ball type lesion is likely suggestive of an RCC, renal cell carcinoma.
Okay.
Yes, sir.
So what is your final conclusion?
Sir, in summary, there is evidence of an asymmetrical circumferential lesion involving the gastroesophageal junction, likely a neoplastic etiology with resultant dilatation, proximal dilatation of the esophagus. There are multiple heterogeneously enhancing lesions seen in the liver, likely metastatic. There is also evidence of another ball type well-defined lesion involving the lower pole of left kidney, likely a neoplastic etiology, uh, most probably a renal cell carcinoma. There is also evidence of absence of contrast opacification in the portal vein and IVC, likely suggestive of thrombosis. There is also evidence of ascites seen. And in chest, there was evidence of extensive emphysematous changes in the bilateral lung parenchyma, as well as some reticular opacifications seen in the basal segments of bilateral lower lobes. I will inform these findings to the referring physician. This patient will require referral to the upper GI MDT as well as renal MDT for further discussion. The patient will require a biopsy for further evaluation.
Okay, thank you. So in this case, and by the way, these kinds of cases do come in the exam. They have come in the long cases, particularly. It is a bit too much that anybody will show you on a Viva case. They won't show you as a Viva case, but these kinds of. So there is also lung lesion here, metastasis. And with that, so this is the metastasis I'm talking about. And with emphysema was there. There is we can see that dilated esophagus with a air fluid level, and then at the gastroesophageal junction, we can see this tumor, which actually extends to the gastroesophageal junction. It invades the crust of the diaphragm, so a T4 tumor, and then we have got liver metastasis. And with that, there might be, though we have not been provided with non-enhanced, the suggestion of porcelain gallbladder, some calcification there. We know that porcelain gallbladder is associated with malignancy. It's just an academic exercise here in this particular case. This adrenal, quite bulky, may be involved. This is the RCC. And then if you see the bladder, there is another lesion here. By the way, in this exam, people got a similar type of, in the long cases, UB, ureterovesical junction tumor. So this is a urinary bladder tumor also with ascites. And now, as far as your hypothesis of IVC, that is, I believe, an overcall. Please remember that it all depends on the venous return which comes. Now, if you see this, look at the corticomedullary differentiation. It is just an early portal venous phase. So the point is that is contrast coming back from the lower legs, and even here it is not visible. So you should have slightly undercall that. Even if you were worried, you would have said that I would like to confirm it on a Doppler or ultrasound. This is classical layering phenomena. You cannot be sure. You can see the layering here where I am pointing out. So IVC is quite a even now here. Do you see this? This is the hepatic IVC, so the hepatic veins must be functioning well. Even here you can see it. So portal vein was well picked up, and maybe there is cavernous transformation here. You see all of this clutter of veins, and some of them are along the gallbladder also. You see this thing? So these are all cavernous transformation because of portal vein thrombosis. You did ask for the bone window. The patient also had diffuse bony metastasis. All said and done, I just wanted to show you a case which is a very, very busy case. But please remember, they do come in the long cases. Overall,
Thank you,
well
sir.
done once again. Your last case. This 70 A&E, stroke-like symptoms, NIHSS7, right facial. So this is a stroke scan, by the way, for
Yes,
thrombolysis.
sir.
Over to
Just
you.
take a moment to scroll through the images.
By the way, candidate 3, one thing which I have seen as a habit, this is the feedback. When you say, I will take a time, then you keep quiet for too long. That is not on. You cannot keep quiet like the way you actually saw the chest, then you saw and there was a huge silence. Don't do that.
Okay, sir.
It is a good idea to scroll it quickly, but then start describing. Give a running commentary to the examiner that I'm looking at the liver, I'm looking at this, I'm looking at that, whatever you are doing. But your silence was too long at times. Over to you.
Okay, sir. Sorry, sir. The plain CT images of a female patient have been provided. I'm just scrolling from the bottom. I'm looking at the posterior fossa. There is no evidence of any obvious hypodensity seen in the bilateral cerebellar hemispheres or the brainstem. Both the ventricles appear prominent. There is evidence of a there's evidence of a hyperdense area seen in the right frontal region. There is also evidence of intraventricular extension of the hematoma in occipital horns of bilateral lateral ventricles. Uh, Based on these findings, this is likely a intraventricular intracerebral hematoma seen in the right frontal region with intraventricular extension in the form of occipital horns of bilateral lateral ventricles. There is no evidence of any obvious midline shift. There is some focal perifocal edema with effacement of the frontal horn of right lateral ventricle. I would like to immediately pick up the phone and call the referring clinician and inform him the findings.
So you mean to say this is an intraparenchymal hemorrhage with intraventricular hemorrhage?
Yes, sir.
So where is it located? Where is it located, the hemorrhage, intraparenchymal?
Sir, I would like to just see these images in the coronal plane to.
Coronal plane. Okay,
Yes.
just 1 second. Over to you.
It's not moving actually. Yeah. There is evidence of, sir, the bleed is in the right frontal region. It's in the neuroparenchyma in the right frontal region. This is not an classical site for a hyperdense bleed. Usually the hypertensive bleeds are seen in the basal ganglia and thalamus. I would like to further inquire about the history of the patient.
I've given you the history.
Yes.
Patient we came to A&E and patient is 74 and NIHS is 7. This was asked by the stroke team.
This could also possibly be a ruptured aneurysm. However, there is no evidence of any obvious SCH seen in the basal cisterns or sylvian fissure in that region.
Okay, just 1 second. An MR was done.
Yes, sir. Just so the bleed appears to be probably in the rostrum of right half of corpus callosum. With intraventricular extension seen, sir.
Any other sequence you want to see?
Sir, I would like to see T1 weighted images and diffusion weighted images, sir.
Leave the mouse. Diffusion weighted is irrelevant for you.
T1 weighted images.
This is a T1.
Uh, So I would also like to see MR angio if it was done, MR angio images if it was done.
And MRNG was not done.
Okay. So there is evidence of
Any
T1.
other thing you want to see?
Any other, sir? Pardon?
Sequence you want to see?
SWI, sir.
T2 star is there.
Yes. So on looking at the SWI
Just
images,
conclude the case. If you want to see
yes.
see anything else, ask or just conclude the case.
So on looking at the SWI images, this hemorrhages appears to be in continuation with the right anterior communicating artery. I would therefore the probability of a ruptured aneurysm is more likely than a hematoma. I would like to inform these findings to the referring clinician and also request for an MR angio to confirm the possibility of
What
an
is the
aneurysm.
investigation of choice to for an aneurysm? Is it an MR angio?
CT angiography, sir, or digital subtraction angiography.
Over to you.
So there is evidence of an aneurysm seen involving the right AC anterior cerebral artery. It appears to have ruptured. Yes,
Which
sir.
segment of the artery is this?
Pericallosal segment of right ACA.
Okay, thank you.
Yes.
Now, by the way, you did very well, but there were points where you took too long to go for the next step. You should not do that. Number two, think like this. What happens in the real world? You don't ask for conventional NGO like this.
Yes, sir.
The CT is the best imaging modality if you want to do what we call imaging for any aneurysm, and it is
Yes,
the
sir.
most available also. So these things matter in the exam because the examiner will, you cannot do by the way, in this particular case, you have to act very quickly what is happening. So these can, though your thought process or everything else was absolutely fine, but this is my reflection that you have to do not take too much time to go for the next step.
Yes, sir.
Otherwise, it was well done. Now,
Thank you, sir.
so this was a giant aneurysm, and this was the pre-callosal anterior cerebral artery. The most common sites of aneurysms are on this diagram. One is anterior communicating, then is the bifurcation of the MCA, then is the origin of the PCOM at the ACA, and then is the bifurcation of the basilar. So these are the top four sites. But if you see the anatomy of the anterior cerebral artery, we have got 5 segments. A1 segment, which is pre-communicating, this is the anterior communicating artery. Then we call it the posterior communicating segment, which is the A2. This is where the aneurysm was, and the candidate picked it up in the end very well. Pre-callosal. This is the corpus callosum. The genu is sitting here, and I will show you the imaging. And then is the supracallosal A4 and the posterior callosal. In the exam, sometimes they will show you this is a branch which is closomarginal, but the main segments are these ones. In the exam, and this has happened in the past also, if they show you a conventional angio, they will ask you anatomy. And I always tell my students that though chances of getting a conventional angio in neuro is quite less, but still there are chances. And whenever they will show you, they will show you anatomy. What is this? What is this? What is this? Show me this, show me that. So closer to the exam, on an atlas or something, just do some rehearsal and your anatomy should be there. Giant aneurysms. This was a giant aneurysms. Please remember, that giant aneurysms will always give you bizarre signal intensities on MR. And usually they will start from an MR. And my case, the anatomy was quite, unusual. So that is why I started with the CT. I could have simply started with the MR. And it will give you bizarre signal intensity. And why? Because part of it will be thrombosed and part of it will not be thrombosed. And then the flow inside will be of various velocities. Look at this one. This is a giant aneurysm of the bifurcation. You can see a lot of edema. And I will not be surprised that if you get it in the exam, you will start thinking that there is a tumor. And look at the size of this, how big it is. So the eye sees what the mind knows, and you should know that giant aneurysms are real giants. Look at this T2 weighted sequence. Here you can see mass effect on the pons, and there look at the signal intensity. It is absolutely bizarre, but it is a bit rounded. And then when you give contrast, this is a T1 weighted sagittal sequence. You can see part of it is enhancing, part of it is thrombosed, and this is an aneurysm of the basilar artery. Look at this one. This is favorite in the exam. You know, para cavernous sinus or paracellar region is a very important differential diagnosis. If you see here, something is there. And if when we give a contrast, this is a CTA study, and you can see this cavernous and the supraclinoid portion of internal carotid, there is a large aneurysm. And that is why in your differential diagnosis of cavernous sinus or paracellar masses, other than all of these things, vascular as in aneurysm is there, and always remember it because it is quite favorite. This is a large one which is on conventional angiogram. Okay, candidate 2, well done. You did very well.
Thank you, sir.
Candidate 3, are you with us? Let me unmute the candidate. Candidate 3, are you with us?
Yes, sir. I'm here.
Okay, excellent. Still, you are fresh. So ready for the Viva?
Yes, sir.
Okay, well done. This patient came to A&E, 76, male, alcoholic, severe back pain, raised inflammatory markers, and the orthopod saw it. They have written cauda equina question mark. So they're worried about cauda equina syndrome. Over to you.
Can I ask for the remote control?
Yes, please. The control is with you.
Okay. Okay, I'm provided with a MRI sagittal images of a male patient who is presented with a complaint of back pain. I am scrolling through the images to rule out the cauda equina syndrome. I'm scrolling through the images. I can see there are abnormal signals noted within the nerve roots at the level of L1 and L2. These are abnormal hyperintense signals on the T2 images. There is no any disc herniation which compress the nerve root. Um, there is an abnormal signal intensity also noted within the CSF space in the lower lumbosacral lesion. So I will like to see the another images like T1 or the post contrast images if available.
Okay. Leave the mouse, please.
Yes.
This is the T1. Once you see it, then I will
Okay.
show you the post contrast also.
I'm scrolling through the images. There's an abnormal signal intensity mass noted at the region of the pars intra-articularis at the level of L5 vertebral body. It is in hypointense on a T1. It is also involving the posterior element and the paraspinal muscle. Um, so
You
this
want
could
something
be,
else? You want to see more sequences?
yes, I would like to see the post-contrast images.
Okay, just 1 second, please. So before the post contrast, this is the pre contrast. I am scrolling it for you. Just this is the pre contrast.
I can see the enhancements noted in the posterior paraspinal muscle.
Madam, this is pre contrast.
Abnormal hyperintense area within the paraspinal
Right.
muscle.
So you have picked up something here, right?
Yeah.
Okay. So here, let me give you post contrast. This is post contrast. Over to you.
Okay, in these images, I can see there is an
Yeah,
peripheral
you can
enhancing
scroll.
lesion.
You can scroll.
Okay. I'm scrolling through the images. I can see there is a peripheral enhancing collection noted in the posterior paraspinal muscle. It is involving the back, and I can see this is also involving the posterior element of the vertebral bodies. So this is suggestive of abscess in the paraspinal muscle with involvement of the posterior vertebral elements, likely osteomyelitis in this IV drug abuser patient. The enhancement is also noted, peripheral enhancement is also noted within the CSF canal in the lower spinal region at lower sacral region within the CSF canal, which could suggest the epidural abscess. Um, and the enhancements are also noted within the sacral vertebral bodies, which also suggest osteomyelitic changes. So in summary, this is an paraspinal abscess with extension into the vertebral bodies and within the epidural space of the lower sacral region, leading to a epidural abscess. So this can lead to a compression over the nerve root and leads to a caudal syndrome.
So is it involving the sacral canal?
Over here, there is an enhancement.
Any other involvement?
And over here, there is an also involvement within the CSF canal.
Right. Okay. Thank you. So basically the diagnosis is correct, but I just want to point out a few further findings. Now, first of all, on this T2 weighted sequence, so this is a case of spinal infection with multi-level epidural abscesses, paravertebral abscesses, etc. Now, on this T2 weighted sequence, you describe that there is abnormal signal. The main finding here is clumping of the nerve roots. That is the main finding. Usually the nerve roots are not clumped like this. So that is the main finding which I was trying to listen to. What does it tell you? When there is clumping of nerve roots, means something might be actually sitting right and left, which is compressing the thecal sac. So that is one finding on this T2 weighted sequence. Now, of course, even here you can see that collection now you asked for a T1 weighted sequence, which was this one. On the T1 weighted sequence, you did pick up this abnormal signal in the posterior elements. Always comment on signal intensity, which is lower. So abnormal marrow signal is usually lower in signal as compared to the intervertebral disc. And you must say that rest of the vertebral bodies, they have got normal marrow. But before that, for going for post-contrast or anything, ask for a stir sequence. Please remember that the two are stir and T1. So ask for a stir sequence and only then go for post. Lot of, the abscesses are there. Posterior elements, abnormal marrow signal, which was low on T1. Now you can see this is high on the stir sequence. And with that, of course, just like you, we will see on post contrast what is this was, of course, the pre-contrast fat saturated. We have got posterior paravertebral abscesses. We have got involvement of the posterior elements at L4, L5. We can see a lot of enhancement, means phlegmon. But whenever you see marginal enhancement with necrosis, means this is an abscess. So for example, here is an abscess. Look here, there is an abscess sitting here. And then look more superiorly. Here you are. So there is an abscess sitting here. There is an abscess sitting here. So everything is on fire. And this is 5, 4, 3, 2, 1, 12, 11. So, and the cord is sitting next to it. So I did not show you, or you did, the axial, but of course on axial you see similar findings. So multi-level epidural abscesses. So this is what it was. Okay, you did well. Next is, yes. So this is a GP X-ray. 68 male GP, has done this X-ray just for cough off and on. Madam, you are with me?
Sir, I could not see the screen. Oh.
Okay, sorry. Let me share again. Yes, please.
Okay. I am provided with a frontal radiograph of an 60-year-old male patient who is presented with a complaint of cough. Looking at the radiograph, I can appreciate that there is an there is a widening of the rib noted on the right side. I think this is the right eighth and seventh rib, which are appears expanded. Um, Apart from the other ribs appears normal. There is no any lung nodule or mass noted within the lung. There is the costo-phrenic angle appears clear. There is no any pleural diffusion, no pneumothorax. The cardiac contour appears normal. I can see that there is an opacity noted in the right paravertebral region. This could represent a hiatus hernia, or this could represent mass within the posterior compartment, like paravertebral abscess. So I will go for contrast CT scan of the chest to further evaluate. And
Okay.
apart from
Actually,
that,
a chest X-ray lateral was done.
looking at the lateral radiograph, there is an opacity noted at the lower lobe region.
Lower?
It is a biconvex shape.
Sorry, say again.
There is an opacity noted in the lower lobe. It is of biconvex shape.
What are you seeing? Can you point out?
Over here.
I'll give you ask for the mouse. Have you got the control?
I have asked for the remote control.
Okay, now it is with you.
Okay,
Hold it
I'm
there.
talking about this opacity.
I cannot see your mouse moving. Can you? You are moving?
Yes, I'm moving the mouse.
Okay, so you are saying that there is something in the lower lobe. What do you mean the lower lobe? Where?
You cannot see my mouse.
No, I cannot.
Okay, so
Describe it. Describe it for me.
yes, I can see the opacity in the right cardiophrenic angle.
Cardiophrenic angle. So you mean
Yes,
to say it's
in the
anteriorly
anterior
placed?
compartment at a cardiophrenic angle.
Do you think anything is abnormal in this region?
Yeah, I was pointing out this. So initially, I was pointing this. There is an opacity in the lower zone.
So what can it be?
This can be I can see the air bronchogram within it. So this can be a pneumonia, or this can be a mass within the lung. So I will proceed with the contrast and CT scan of the chest for further characterization.
So the pneumonia of the lung, it will project like this.
No. This can be and I want to see the lateral radiograph again. Sorry. This is adjacent to the vertebral bodies and in the posterior.
So what can it be? What is the differential considering the location?
The vertebral bodies appears normal, so this is not related to a paravertebral abscess or something. This This can be a hiatus hernia or related to the esophagus.
Okay.
Or this can be a...
Okay, let me show you a CT scan. Over to you. You can ask for the mouse if you cannot control it. Maybe it is with you. Control, I mean to say.
Yes, I can scroll the images. I'm scrolling the image from top to bottom. I'm going downward. I'm scrolling through the image to look for the abnormalities. There is no any lymphadenopathy in the mediastinum. I'm going down. Till now, I could not find any abnormality. I can see there is an soft tissue density, a low density mass noted in the posterior mediastinum. It is of low density. In my routine practice, I will check the HU of the patient, HU of the mass. I can see there is an fatty within this mass lesion. There is a mass with a fat containing the fat in the posterior mediastinum. This can be a germs and tumor, but usually this occur in the anterior mediastinum. I can see the fat contents are herniating from the lower abdomen within the chest. So this can be a diaphragmatic hernia with herniation of the bowel loop. But
Would you like to see anything else?
I would like to see the coronal images.
Coronal.
I'm scrolling through the images. It is taking time. Yes, I can see there is an herniation of the fat with the soft tissue component.
So what is this soft tissue component, which actually this is a fluid component? How do you explain that?
I'm looking for if there's any connection with the esophagus.
Okay, conclude it. Final diagnosis.
So there is a lesion with a fluid and fat component within it in the posterior mediastinum, which seems to be extending into the abdomen as well. This can be a esophageal duplication cyst. However, I could not find any connection with it. This can be a hernia with fat content herniating with the bowel loop.
Okay,
Other I could not make out anything.
thank you. So this was the last case, spinal epidural abscesses. This is a diaphragmatic hernia, simple as that. And this is a type of a discussion case. Now, the point is that, first of all, you have to have, let's revise a lateral chest X-ray. Lateral chest X-ray can still come in the exam, and it has happened in FRCR exam that one of the candidate who was my registrar got a lateral chest X-ray as the first, X-ray instead of a PA fill. And so please remember that the current generation of radiologists, you don't see lateral chest X-rays for the simple reason that now we go for CT scan immediately. But please also remember that lateral chest X-ray is still one of the basic views of chest. PA and lateral is still a basic view. So you should know lateral chest X-ray. Lateral chest X-ray is a good X-ray to diagnose or to location-wise to characterize masses of the mediastinum. And this is what this case was about. And so I wanted to check your knowledge on the lateral chest X-ray because there are specific areas. According to the areas, there is specific differential diagnosis. I think the candidate did well where pointed out esophageal or hiatus hernia, but so that was the exercise about. On a lateral chest X-ray, they will ask you anatomy also. What is this? Which diaphragm is this? Which diaphragm is this? This is the retrosternal space. This is the the retrocardiac space. And there is a concept of increasing translucency as we go down the thoracic spine because the lung becomes bigger and bigger in volume, I mean to say. So I don't have time to teach you the whole lateral chest X-ray, but I just wanted to highlight this thing. Now, look at this picture, and this is from, I think, David Sutton. Just remember it, and the same concept is given in Chapman, which I'll show you. This is the anterior mediastinum, the middle and the posterior mediastinum. Just remember it as area 1, 2, 3, 4, 5, 6. Our case was in area 6 and then 7. And there is a particular differential diagnosis. And this is the area 6. This is where our case was. And hiatus hernia, aneurysm, esophageal dilatation, etc. And of course, you can add any other diaphragmatic hernia also. This is the same concept on lateral X-ray, in Chapman. So this is the anterior mediastinum, area 1, 2, 3. And this is the differential diagnosis of area or region 1, region 2, region 3, whatever you want to call it. There is a hernia there. We call it Morgagni hernia, which is anteriorly. So this is Morgagni hernia classical location. And this per se is an exam case because of location. It will be right, paracardiac, and it will be anteriorly placed, the region 3. So this is Morgagni hernia. There is fat inside. Now there is posterior mediastinum, and here this is slightly different than what the concept on Chapman, but the differential remains the same. For example, in region 2, this is region 2, dilated esophagus, descending aorta, esophageal duplication cyst, and region 3 is hiatus hernia. So then there is another differential diagnosis in your book, which is mediastinal mass containing fat, hernia containing fat. So that was a pitfall in this case. There was fat, but that was normal abdominal fat or which had gone in. And it can be hiatal hernia, it can be Morgagni hernia, it can be Bogdelic, which usually they will show you pediatric films for that. And teratodermoid, of course, in anterior mediastinum. And so let's go back to the case. It was a simple case, but the thought process is what was needed here. So if you see here, this is the opacity. You can see this is the opacity, which was well described by the candidate. And this is where it is. According to Saturn, this is area 6 or region 3, whatever you want to call it. Something is happening there. And you can see increasing translucency of the vertebra as we go distally. That is also disturbed. So something is happening there. And this finding is the main thing to be pointing out. And now, in this case, what has happened is that there is a hernia, and with that, there is trapped fluid inside. We call it entrapped fluid. And in your clinical practice, you might have seen similar findings in inguinal hernia many times on a CT scan, where there is trapped fluid. So fluid goes in and it just gets trapped there and should not be of any definite clinical significance. The candidate did well, was looking for any hernia, asked for a coronal, which showed you that here you are. Look at, for example, this vessel, and trace this vessel, and everything is going into the hernial sac. If I show you a sagittal, you will again see it, and this you will be able to relate it with the lateral X-ray. So this is the diaphragm, and here you are. You can see vessels going in, and you can see that there is a bit of trapped fluid. So I think this lateral really helps you consolidate the findings on the lateral X-ray. Okay, good, well done. Second last case of the day. Madam, are you with us?
Yes, sir.
Okay, so this one is 75-year-old, again, A&E case, weight loss, fever, abdominal pain off and on, fever off and on, and generally unwell. Previous history of CA colon. Rule out malignancy, question mark. Over to you, rule out cause. We did a CT chest, abdomen, and pelvis. The chest part was normal. I don't want you to worry about that. Please concentrate on this abdomen. Over to you.
Okay, I asked for the remote control.
Yes, please.
Okay. I am provided with a CT axial images of an abdomen, post-contrast images. I am scrolling through top to bottom. The patient is present with a complaint of abdominal pain and the fever. Here I can see there is a large multiloculated lesion noted in the left lobe of the liver. I'm scrolling further. The portal vein appears normal. There is no any thrombosis. The both kidney appears normal.
Okay, just concentrate on the lesion which you have picked up. I'm not interested in anything else.
Okay. So there is a multiloculated lesion within the left lobe of the liver. It has a septa which are enhancing. It is displacing the adjacent hepatic vessels. So the differential for this multiloculated hepatic lesion, this could be an abscess. This can be a hydrated cyst. The mets are less likely. Metastasis are less likely because this is a single, and the appearance of metastasis is like slightly. Apart from that, the primary hepatic tumors are also less likely. So this is likely an infective etiology, likely an abscess, or could be a hydrated cyst.
Okay, just 1 second. What do you think is where I'm pointing out? You know this. What is this?
I could not see the your marker.
Is there some high density focus where I'm in the
Yes,
center?
yes.
What is this?
On this can be a foreign body. I have to scroll on to trace it is where it is coming from.
You would like to see something else? Some other sequence?
Or some others. I would like to see the coronal images.
These are the coronal images.
Okay, I'm provided with the coronal images of the abdomen. There is again a multilocated cystic lesion. There is a tube noted. This can be a VP shunt.
VP shunt.
Sorry, this can be a stent for which is
Nothing like that was done.
okay. So this is an I think tube is coming from the duodenum going into the maybe a liver. So it is perforated the duodenum and leads to a liver abscess.
This is the stomach.
I can say this is going from there is an irregularity noted at the region of the
Okay, so what is your
pylorus
conclusion
or.
then?
So this is I think a foreign body or tube
Okay,
coming
and
from the
what is
stomach
this
and
lesion?
leading to this lesion. This can be a hepatic abscess or hydatid cyst.
How can you confirm it?
I will advise the serum marker and the antigen test for hydatid and
Imaging wise,
also
can
call
you do anything else?
the drainage of the abscess can be done after
That
aspiration, which
any other imaging?
MRI of the abdomen can be done to confirm it.
So this is the MR.
I am provided with the MRI axial images of the abdomen and where I can see there is an abnormal signal intensity lesion noted within the left lobe of liver, returning internal hyperintense signals with heterogeneous hyper.
I'm
So
showing
this is
you
the
both
post-contrast images, arterial phase, where there is the lesions shows peripheral enhancement with enhancing of the septa. There is a subcapsular, there is an enhancement of the liver at its subcapsular lesion in the left lobe. So this can be a this there are low density area with peripheral enhancement are also noted within the liver. So this can be a ruptured abscess within the liver
ruptured
parenchyma.
abscess. So what is your final differential for this?
Still, I'm thinking of infective etiology. Likely
Anything which can confirm this diagnosis for you on this MR?
maybe a delayed or portovenous phase of MRI.
What is this?
This is a diffusion restriction images.
What does it tell you?
It shows a diffusion restriction which confirm that this is an abscess within the liver.
Thank you. You see, the thought process, this is a very simple case, and you reach the diagnosis very quickly, but the thought process. Now, this is a case of, this is a fish bone, actually. And you have to stretch your imagination that what has happened this. Fish bones, if you had asked me densities and things like that, I would have provided that. It is known that fish bones can do, unbelievable things. And there are case reports where fish bones were eaten, perforated the bowel, went into a vessel, and then was found at another site. So first of all, you have to know that. Number two is that uh, in this case, the hypothesis is that it just perforated through the stomach and went inside. So this is a fish bone. And number two, we have got this multiloculated rim enhancement. Hydrated cyst will not show enhancement like this. So should not be, you should have ruled it out even on a CT scan. Of course, your question was, answer was correct that I will just go for an ultrasound guided aspiration to confirm it. And it can be also a therapeutic. But I wanted you to confirm it. In UK, we do MR livers like you do CT scans. Remember, MR livers are done very commonly here. So MR liver is an exam case and you should know it. And the key thing is that in MR liver, just 1 second. So these are the sequences which are done, or the variations of these are done. This is our protocol in our hospital. If you see, we are doing a T2 coronal, T2 highly T2 axial, T2 axial, in phase and opposed phase. These are exam sequences because fatty liver, also adrenal adenomas. For adrenal, the same case, same one will come to you. And out of phase, there is a etching artifact, India ink artifact around the organs. The examiner is not going to show you that, tell you that this is out of phase. You are going to pick it up. So develop your eyes on out of phase sequence where there will be a black line around the organs, etching artifact or India ink artifact. Anything which becomes darker as compared to the in phase has got fatty component. Same concept is used for adrenal adenomas or fatty liver or fat containing tumors in the liver, etc. This is the DWI sequence, and this is what I was asking you. When we do DWI sequence, we increase the B values. In our department, we are using B0, B300, B600, B1200. So this is the highest B value. Just see how things behave on this. Anything which is bright on the highest B value means restricted diffusion. ADC map is a lot of noise there, and on liver imaging, don't bother about ADC map. Just go for highest B value. Then we do a fat saturated T1 pre-contrast sequence, followed by, these are done with auto injector. So this is an arterial phase. This is a 70-second delay. Venous phase, 3-minute delay, 5-minute delay, 10-minute delay. This is what we call equilibrium phase. When we do the scan with hepatobiliary specific contrast, in UK, the trademark is Primovis. We do another phase, which is a 20-minute delay. On this 20-minute delay, it is excreted by the hepatocytes, and now you can differentiate between FNH and adenoma. Coming back to your case, so candidate 3, you have to really and ask for the next thing. Even in the chest case, you see, when things, you will immediately ask for a corona. Say that this is it, and I want to confirm it on the, don't take time, because time is yours. And similarly, in this case, if once MR is there, then ask for next sequence, which is, I want to see this, I want to see that, I want to be very proactive. Time is yours. Remember my words. Time is yours. You have to be very proactive.
Yes, sir.
So this was it. And so fishbone was something quite interesting in this case. Even if you don't diagnose it, I will still, you will be passed there. But the same thing, I wanted to see that if you will ask for the DWI, and DWI tells you that this is what it is. Last case of the day. Last case of the day. Easy case. It is stuck. Hello, hello. Madam?
Yes, sir.
So this is a 10-year-old epileptic. So has presented with an epileptic fit 2-3 days ago. And over to you.
Uh, I'm asking for the remote control.
Yeah.
Okay. I am provided with the MRI images of a 6-year-old patient who is presented with a complaint of epilepsy. So I'm scrolling through the images. These are the failure axial images of the brain. I can see there is an abnormal hypointense signals are noted within the right temporal lobe. And within the right temporal lobe. Apart from that, I'm scrolling till the last end of the section. So I could not find any space occupying lesion within the brain. Okay. So so in this section, I can find that there is an abnormal hypointense signals. Further hypointense signals are seen within the right temporal lobe.
Temporal lobe. So what did you say? You can see or you cannot see? What
I
did you
can
say?
see.
Where is it? Temporal lobe.
Over here within the right temporal lobe.
Don't worry, that's just, a projectional or whatever. Don't worry about it.
Okay. The ventricles appears normal. There is no hydrocephalus is noted. There are abnormal hypointense signals are seen within the corpus callosum anteriorly and also within the frontal lobe in the white matter.
Don't worry about that. That's normal.
Okay. So there can be some cortical dysplasia which usually present with the epilepsy. So I'm looking for this.
Where do you look for cortical dysplasia, heterotopia? Where for?
I can see there is a paucity of the sulci noted within the parieto-temporal region. This could suggest a license cephaly. I will look at.
Don't worry about this. Okay, let me ask you a question. I am moving the mouse. What do you think is this finding here?
I could not see your cursor.
Okay, look at the periventricular region on the left side, adjacent to the body.
Okay, so there is a subependymal nodule is noted, which is isointense to a gray matter on the film image. I will look the other images T1 and T2. If it is isointense to a gray matter, so this is a
Okay,
gray matter
stop.
heterotopia.
So the case was gray matter subependymal heterotopia. Now, subependymal heterotopia is an exam case. The most common one which they will ask you is subependymal. Please remember, it can also be seen on a CT scan. I'm showing you here. Look at it. The key finding is, please remember the concept behind it. There is a concept of germinal matrix in the fetus, and here the gray matter cells they are produced in the periventricular region, and then there is a phenomenon of migration. So they migrate through the white matter to the cortex. Sometimes they get arrested. They can arrest it in subependymal region, which is what they ask in the exam. They can also arrest in the white matter, and sometimes they are jumbled up, though they reach the cortex, but they are abnormal. So location-wise, there can be subependymal white matter or cortical heterotopia. Now, on this CT scan, you can see this nodularity, which is projecting inside the ventricles bilaterally. If you see the density, this density is equal to the gray matter. Same formula can be seen on an MR. Here, if you see, this is the same case, but I've given you slightly lower sequence or cut. You can see something is here, which is equal to the gray matter on T2, on T1, equal to the gray matter, on PD, equal to the gray matter, on flare, equal to the gray matter. So on all sequences, it will be equal to the gray matter. This is an example of subcortical heterotopia. I don't think so. This is an FRCR level case, but you should know many a times when you will report, you will, be worried on a CT scan. Is there a mass there? Go for an MR and it will tell you that there is subcortical heterotopia. The vessels inside will be prominent. Look at the signal intensity. It is equal on all sequences. Look at these vessels. They are very prominent. In this case, there is more to it. If I show you a coronal, you can see that all the way there is arrest here. Compare it from the left side, and you can see that the cells are arrested here and from here till the subcortical region. There is another type of heterotopia, which is known as band heterotopia, in which the arrest is within the white matter. And this particular case, if you see, this is from literature, rather from American College of Radiology. And if you see, this is white matter, ventricle, white matter, then gray matter, then white matter, then gray matter. So as if there is a band, there is a band of heterotopia. I don't think so. This is an exam case, but I just wanted to show you. Now, let's go through your case. So the eye sees what the mind knows. So the key thing is that this is the region. Once you pick it up, then everything, this is a classical where you have to train your eyes with this kind of clinical. This should be one of the checklists for you in future. On a T2 weighted sequence, here you are. You can see it here. You can actually see more here. These nodules. And if you go to a coronal, if you go to any sequence, for example, here is a T1 weighted sequence. And here you are. Look at this one. Look at this nodule, which is equal to gray matter. Look, there is more here, which is projecting inside, and there is nothing on this side. So this is a subtle case, a good case. to develop your eyes on. Here you are. This is a T1 weighted sequence, and you can see it here. You can see it. Just compare it with the other side, and there is nothing there. On a T2 coronal, again, you can see it. Right. So thank you very much.
Thank you, sir.
Well done, candidate 3. Well done. So we very heavyweight type of cases. Some of them were easier, but the point is that I wanted to show you heavyweight cases, and some of them are not exactly suitable for Viva, but I told you that at least, particularly that case of, multifocal malignancies, maybe 3 different primaries, and cavernous transformation and so many things. So these kinds of things have come in long cases, and beware of them. Even in this exam, there was a lesion in the ureterovesical junction in one of the long cases, just like the case which I showed you, satisfaction of search. Okay, then, thank you very much. So the feedback form is up there, and please give us the feedback. And I think the program's next few sessions are